Good morning, everybody. Thank you, Michele, for the introduction. So I was already sure and convinced that everybody came to listen to the wise guys. Now I'm totally out of the picture. But anyway, I'm going to try to do in about 15 minutes just a little overview on Botox, which is distributed in two parts. The first time, maybe more technical aspects, and the second one, open controversies about botulinum toxin. So why are we talking about botulinum toxin today? Well, mainly because of antimuscarinics. Because 25 to 40% of patients fail to get adequate symptom relief from that treatment for different causes, but mostly because of adverse events. First one, dry mouth of patients, and constipation, which is something that usually those are the two main troubles of our patients with antimuscarinics drug. So the toxin, how does it work? So as you know, it is the most potent naturally neurotoxin known. It causes flaccid paralysis of the muscles by blocking presynaptic release of acetylcholine. There are 7 different subtypes of toxin. Types A and B have been used in on medical issues, but the type A is the one which is mostly used in neurology. So once again, how does it work? This is more or less the normal synaptic, where you have the release of acetylcholine. The vesicle just links to the membrane thanks to a snare protein complex. And the Botox just works by cleaving that protein complex and blocking the release of acetylcholine. This is a little bit more simple, but more or less, Botox compromises SNAP25 and prevents acetylcholine fusion with the membrane and release. What are the other effects that have been seen in the literature? It's also the inhibition of acetylcholine and ATP from urothelium in rats. It inhibits the release of CGRP. It inhibits substance P and glutamate. All different studies that have found in the rat model that botulinum toxin does not only work on acetylcholine, but works also on different pathways, which will definitely have a role. We'll see a little bit later on. So what are the milestones of Botox? As Michele said, it was first described by Dijkstra in 1987, where its use, however, its first use was on the sphincter muscle to treat DSD, which is not its use today. And but the great step forward was thanks to that publication by Brigitte Church. I'm not saying it because she's in the room, but I did the slides before, knowing she would be there. But which was really the biggest article that got out. Then the second important step, the second important milestone, was its approval by the FDA. As many drugs, if you don't get approved, you have no chance of going along. So that was really one of the main steps where it approved it to treat specific form of urinary incontinence, and especially in the neurologic conditions such as spinal cord injury and multiple sclerosis, and in the treatment of overactive bladder. So in fact, today, in the European guidelines on neurourology, the toxin injection is the most effective minimally invasive treatment to reduce neurogenic diffuser overactivity in multiple sclerosis patients and spinal cord injury patients. So that makes lots of indications. As you can see, in spinal cord injury patients, but also in stroke patients, Alzheimer's disease patients, Parkinsons, cerebral palsy, and multiple sclerosis. So nowadays, there's really, really a big range of indications for the use of botulinum toxin. From a technical point of view, however, it's important to point out that there are some rules to follow. Usually the people from Allergan will tell you what the rules are, but one of the first is to have a correct storage of Botox. You need to have it in cold conditions to keep it cold. Otherwise, you will have an effect on the quality of the injections. Then the preparation. Just as James Bond says, it's better to have it stirred, not shaken, and that will have an effect definitely on the effect of your injections. So how should you proceed with the injection? There's this nice review which was done by the Notville team and BGUI, which just describes the technique, which can be done with a rigid cystoscope or a flexible cystoscope, which can be very useful on an ambulatory basis, especially in spinal cord injury patients since they lost sensitiveness. Usually the injection is done after local anesthesia, which is done through an installation of lidocaine mixed with saline an hour before the procedure. Then the injection is performed through special needles. Now I think there are lots of them which are available in business. But the idea is to start with different lines, avoiding the trigone and going upwards. The adverse events of Botox or Botox disasters. The main adverse events remain urinary tract infection. But why is that? That's because mostly the use of Botox will paralyze your detrusor. So in a patient which should void spontaneously, it will cause post-void residue, which will cause the infection. However, in our population of patients, of neurological patients, usually these patients will do self-catheterization. And in multiple sclerosis patients, we'll see after that they do not need to do it often, but they need to have the teaching to self-catheterization as it is mandatory to have the urine out when you use Botox in patients. You have some life-threatening events when using Botox. Fortunately, they have low reported rates in the literature from 2 to 6%, but it's important to learn to recognize them. And those will be muscle weaknesses, swallowing difficulties, and breathing difficulties. But usually when that happens with your patients, when the patient starts to tell you, I'm having a tough time breathing, you're not going to send him home. So eventually, that's going to help you find out that it's a dangerous event. What are the benefits of Botox? Well, unlike tequila, they have different effects. That's a review of all the current studies that we have in the literature, which more or less show all the clinical benefits of the toxin. Most importantly is the improvement of urinary incontinence. Why? Because we have an increase of maximum cystometric capacity and a decrease in maximum detrusor pressure. Also, Botox helps us, therefore, in reduce the use of anticholinergics that usually patients stop using, and that is why we switch to Botox. One of the most important things in neurological patients will be the preservation of upper urinary tract. Since we have a decrease of the maximum detrusor pressure, we will have a reduction of occurrence of reflux, and therefore a decrease of infections of the upper urinary tract, and therefore a preservation of kidney function, which is one of the main objectives of the management of urological disorder in neurogenic patients. Also, I know it's a little bit contradictory what I said before, but you will have a decrease in lower urinary tract infection. Why? Because thanks to lesser detrusor contraction, you will have improved blood flow, and therefore you will have less infections. Most of all, you will have an improvement of the quality of life of patients, and you can also have a reduction in autonomic dysreflexia. Important, it is cost effective. So in our modern societies, it is important to find therapies and treatments that are not too expensive for society. And so it seems for Botox, it is considering the anticholinergic therapy and its cost, but also considering all the resources used to treat UTIs in patients which are not correctly managed, as well as continence devices and also the renal insufficiency. Focusing a little bit on different pathologies, as far as multiple sclerosis, you see that botulinum toxin is effective and well tolerated. There's no difference of efficacy in confront to spinal cord injury patients. The response rate can reach 90%, and the duration of treatment is also comparable, reaching 9 months. The most frequently used dose in open label studies is around 300 units. However, in RCTs, we have 200 units. We'll talk about the dose when we talk a bit about the controversy. It is seen so that we have the same efficacy and duration, and it is important to point out that you can use lower dosage in patients who wish to void spontaneously or that can void spontaneously. But we'll talk a bit about it later. As I said before, all patients should be instructed to self-catheterize. Parkinson's disease. Botox enables decreased daytime and nighttime urinary frequency, the number of urinary incontinence episodes, and increases maximum cystometric capacity. It seemed to have no effect on central nervous system, which is an issue that we have with antimuscarinics when you're talking to a neurologist. And usually that's a recurrent fight over coffee in the morning with our colleagues. So, but it is important to point out that, unfortunately, the studies in the literature have few patients, and that's one of the biggest difficulties that we have with neurogenic bladder. Botox and detrusor sphincter dyssynergia. As we said, it was the first description of the use of Botox in 1988 with Dysport. We have different studies that went out, including one of Michele's, who was in 1998, where they showed that it was efficient. Otherwise, there are very few studies in the literature on its use in DSD. Otherwise, you have to learn Russian, because one of the latest articles is only in Russian. So, but it shows its efficiency in that setting. However, it is important to point out that for the guidelines, it can be used for DSD. However, it is not yet licensed, and mostly the main problem is that you don't know how long the effect is going to last on the sphincter. So it is not yet approved just as for detrusor of activity treatment. Controversies on Botox. Reduction of effect throughout the years. It seems that after several injections, the effect of Botox tends to go down. One of the main hypotheses was the one that antibodies against a toxin could arise and diminish its effect. However, in the literature, only two studies, I only identified two studies, one by Brigitte Schürch and one by Francisco Cruz, where they didn't find any antibodies. There was no evidence of loss of efficiency in these studies. However, no large RCTs. Maybe not, because now there seemed to be an interest in that. That was a presentation, a poster presentation in Stockholm on 397 patients, which 200 had a 4-year follow-up. And the aim was to present the results from a multicenter long-term study of Botox for urinary incontinence due to neurogenic detrusor overactivity. And in the conclusions, it seemed that, if it comes, that the use of Botox demonstrated consistent improvement in urinary incontinence and volume void following repeat treatment through 8 cycles, meaning that in their studies, they did not seem to have a reduction of effect by using Botox. That was another study on 72 patients where they used either 200 or 300 repeated detrusor injections. In all of those patients, renal function was maintained in patients receiving both dosage and in repeated injections, once again translating in a continuous effect of a Botox injection and not a loss. Another controversy is the reduction of injection sites. It doesn't matter. This is one study by Pierre Denis, which motivation was the lack of standardization of the technique. And the idea was to see if by reducing the number of sites of botulinum toxin injection, it had an effect on urodynamic. Eventually, it did not. But however, they concluded that a higher number of sites might be more conservative from a safety perspective, since you have to instill less toxin in a single injection. Another controversy that you find in recent publication, does the use of anticholinergic drugs have an effect on the further use of Botox after? Well, in this pooled analysis of more than 1,000 patients, there was no effect of prior antimuscarinic drugs on the effect of Botox after. Dose, as I told you, it is a common controversy or debate. Should we do 300 units, 200 units, or maybe 100 units? Well, in that study, once again, that was by Charté-Kessler on 77 patients. They actually did their study using Dysport, so ababotulinum toxin A, and using different dosage from 750 units to 500 units. And they showed that there was no statistically significant difference in terms of clinical and neurodynamic variables and quality of life of patients. Furthermore, the tolerability was excellent for both doses. So in that case, it seemed it didn't matter. One could lower the dose. That was also the finding of another study by Cruz in 2011, who concluded that lowering the dose to 200 units from 300 units made no statistically significant difference in efficacy and duration. However, in other studies that were presented in Rio in 2014, it seemed that the dose mattered, but that was in a setting of multiple sclerosis patients. In their conclusions, it appears that lowering the dose of anabotulinum toxin A has a good initial response, but in almost a third of patients, the duration does not last as long as the original increased dose. Another study, which was also by Charté-Kessler, proposed that to reduce the dose of Botox to 100 units. And there, once again, in non-catheterizing patients who were inadequately managed by antimuscarinics, treatment with 100 units of Botox resulted in significant and clinically meaningful improvements from baseline in incontinence. So, here it seems that lowering the dose works well in multiple sclerosis patients. And what do the guidelines say on that? Well, actually, the guidelines do not state a lot on the dose we should use. So, doing that review of the literature, that's more or less how I was feeling. Didn't understand which is the correct dose, and that is why this is really an ongoing controversy. One of the last controversies, which is the one between the different types of Botox. As you know, there are now available on the market two different botulinum toxin. One is anabotulinum toxin A, which is Botox. The other one is ababotulinum toxin, which is Dysport. In Switzerland, I think Dysport is not licensed. I don't know if it's licensed in Italy, but nevertheless, there seems to be a little bit of studies treating the matter. For instance, this was a systematic review comparing the two products. And as one could see, the main conclusion of that review is that there are very good quality studies on Botox, and unfortunately, there are not on Dysport. So the conclusion were that this does not imply that Botox is more effective than Dysport, but it should be a consideration when counseling patients that for the moment on Dysport we don't have that much feedback. However, you have different studies that when this is a retrospective case control study in 211 patients that said Dysport 750 versus Botox 200, there was a better outcome of Dysport. When comparing 750 versus 300, there were no differences. So one of the dose issues and the product issues is really the main focus is there. Is Dysport 750 the same as Botox 200, or is Dysport 750 the same as Botox 300? This was another study that was presented in Rio, and it was to evaluate the impact on duration of action and the quality of life in spinal cord injury patients with switching from Botox in patients who previously had Dysport. So 27 patients who all underwent 200 units of Botox. It seemed that the duration of action when using Botox was shorter in confront to Dysport. with an average of almost 4 months to almost 9 months using the Dysport. So it appears that only the dosage between Dysport and Botox are not interchangeable, but also the ratio between the two toxins remains not well defined. So the main conclusion of that study is that we need more RCTs to draw important conclusions. So this is another study that Michele's team did from March 2006 till July 2015. They retrospectively went to look at all the patients that had Dysport before and then had to switch to Botox 200. Out of these 120 patients, the first injections were either 750 of Botox of Dysport or 300 of Botox, and the second injections was Botox 200. The reason of the switch was that in Italy they stopped licensing Botox 300 and Dysport was not available. Looking at the effectiveness on all patients, one could see that the length of effect was more or less the same between 700 units of Dysport and 300 units of Botox. Also, whoops, sorry. Where's the point? There's that. There we go. So you had almost the same duration of effect, or slightly different, between 300, 700 of Botox, 750 of Dysport, and 500 of Dysport. However, already there, you see that the length was clearly, between two injections, were clearly reduced only using 200 units of Botox. So what they did, they also divided it according to disease. So in paraplegic patients, one could see that 750 units of Dysport and 300 units of Botox have the same duration. However, when switching to 200 units of Botox, the duration is shortened. Same conclusions in tetraplegic patients. Same conclusions in multiple sclerosis patients. So overall, the time range from the first and the second administration is reduced in patients treated with Botox at 200 units compared both to the higher dose of 300 units and Dysport 750 or 500. So once again, this is retrospective, this is observational, but this is maybe something that one should try to investigate in RCTs. So more or less the situation is like that between Botox and Dysport. Nobody really can get along. There are many people who sustain Dysport, those who sustain more Botox, but for the moment no one can really draw strong conclusions since we are lacking RCTs. But there is one solution, is that maybe the fail is the switch of toxin. This interesting study, which was published in 2015 in the International Journal of Urology, was a retrospective study on 29 patients out of 59, and these 29 patients had toxin switch. And that was interesting because patients which had loss of efficiency using Botox, when they switched toxin to Dysport, they seem to find a new effect. So that might be a strategy or something interesting to work on, as the switch worked in both ways. As they said here, patients treated from switch from Dysport to Botox and Botox to Dysport had the same effect. So that's interesting. So in conclusion, botulinum toxin is a great weapon today in the management of OAB. It's already a great tool on the efferent side. I didn't show those studies because most of them are on the rat model, but there are some interesting studies on the efferent side, as Botox seems to have an effect on the reduction of ATP and production of NO, having an effect on the afferent signals. So that also might be the next step in studying Botox or botulinum toxin. So it's a work in progress. That's it.